Dear guests, colleagues and friends, صباح الخير وأهلا وسهلا. Just a logistical note before we take off the plane for this conference. ما عم تسمعوا؟ هيك أحسن؟ طيب. Okay, صباح الخير مرة تاني. Can you hear me at the back? Okay, thank you. So just a small announcement before we take off the plane for this meeting. Can I kindly ask you to put your phone on airplane mode? Thank you. So on behalf of the NCD Working Group and the Faculty of Health Sciences, it gives me great pleasure to warmly welcome you at the American University of Beirut and to this meeting entitled Research on Research in the Arab Region, the Case of Non-Communicable Disease. I'm truly delighted to see many familiar faces and such a big crowd of students, faculty, and other professionals from various academic disciplines, local, regional, and international NGOs, including the WHO, EMRO, and Geneva, in addition to some journal editors and peer reviewers. Some of you have traveled here to participate in what we believe will be a stimulating series of presentations and discussions on the topic. In 1812, more than 200 years ago, the very first sentence of the first article in the first issue of the New England Journal of Medicine read, "In our inquiries into any particular subject of medicine, our labors will generally be shortened and directed to their proper objects by a knowledge of preceding discoveries." If this has been the basis of sound research for the last 2 centuries, it is even more imperative today, and particularly in low and middle income countries, where investment in research and development does not exceed 10% of the global research funding. Proposals for research, the very first step before conducting the study, should be justified by reviews, whether literature reviews, systematic reviews, scoping reviews, or more broadly what we label here as research on research. An activity that shows what is already known, what are the gaps in the literature, and what's the added value and the significance of the proposed work. So what brought us to this theme? I guess as we get older with aging, one tends to be bored with the classical investigations. Those studies that explore data from one individual study, whether prevalence studies or risk factor epidemiology, and have more time to reflect on what, how, and why we do research, and start asking ourselves questions. Does my research address a national priority? Are the findings being distorted by poor study design, poor sampling, possibly owing to the lack of sampling frames, selective reporting, or other types of biases? Are all findings being reported, and who is reading my papers? Are we publishing more in one area and less in another? What are the tangible yields, and did this piece of work transcend the boundaries of the institution and impact policy and practice? This meeting comes at the culmination of a 4-year scoping review project that attempts to answer some of these questions. Our study, focusing on NCDs and conducted in selected Arab countries, aimed at understanding existing research on NCDs in the region with a lens of identifying gaps, opportunities, and examining alignment across funding agencies' priorities, research productivity, and disease burden. However, as the NCD scoping review has uncovered the need for a broader scope of overall research production in the region, the meeting will also expand the discussion beyond NCDs to deliberate on issues related to mapping overall health research in the Arab region. The meeting brings together regional researchers involved in the current IDRC-funded study and others who have carried out or are currently conducting regional or national studies on research on health research. The meeting concludes with a multidisciplinary panel discussion, which includes representatives of funding agencies, medical journal editors, and researchers, and those who play a key role in shaping research priorities in Lebanon and the region. Each of our panelists brings forward their own perspective on the topic of the meeting, and I invite all participants to actively engage in the forensic examination of factors that influence the production of responsible research. Issues need to be debated and discussed within a perspective that describes the Arab region, in spite of its heterogeneity, as one with weak research infrastructure, scarce research funds, and where scientists have to deal with rigid university guidelines for promotion, for reappointment, and possibly with journals that they have their own agenda for publicity and possibly profitability. The meeting includes 4 sessions. Each will start by introductory remarks that set the stage for the intended objectives of the session. Before I introduce our first moderator, I would like to extend my appreciation to the organizing committee members, Dr. Soha Yazbek, Samer Jabbour, Salim Adib, and to note the hard work of the soldiers behind the scene, Aya Nubani, Maria Panshiri, and Amani Zaidan, and to thank them for their great contributions for the preparation for this meeting. Without further delay, please join me in welcoming Dr. Samer Jabbour, who will be moderating the opening session and presenting its introductory remarks. Samer is a cardiologist and associate professor of public health practice at the Faculty of Health Sciences, AUB, and a specialist in NCDs. He served as a director of the Department of NCDs and Mental Health at the WHO Regional Office for the Eastern Mediterranean region between 2013 and 2015, and was the lead editor of the book Public Health in the Arab World, published in 2012. He is a member of the AUB NCD Scoping Review Working Group. Samer, the floor is yours.
Thank you very much. Good morning, everyone. Sabah al khair. We actually, the idea of having a brief introduction to the subject of NCDs for this session just came up this week. So knowing that a lot of you were specialists, I was reluctant to do such a presentation. But knowing also that some of you may not necessarily be NCD specialists, and we may have also students in the rooms, please forgive me. I'm going to review things that are familiar to you. Yes. So for this session, we are going to bring together three perspectives that really touch on 3 subjects are of crucial importance throughout our discussion. For this session, we're actually going to raise questions rather than provide answers that touch on 3 dimensions. The first dimension is the dimension of adaptation of a global agenda for research and how this fits with public health priority. The second is that how we move from once we've generated some research into policy impact. And the third presentation will be about what the roles of academic institutions ought to be in terms of translating this evidence and the knowledge translation component of it into impact. As you could imagine, if you look at your agenda, the very last session is also tackling some of these same subjects. So this is a discussion that starts with this morning and continues throughout the day. End of slide. So my presentation was there somewhere. Actually, Shadi, I think here you go. Oh, here. Okay, good enough. No, I'm good. Thank you. I looked last evening at reviews of NCDs in the Arab world. And it's actually, interestingly, I found a lot of topical reviews under NCDs, but not necessarily broad reviews of NCDs in the Arab region, taking the Arab region as a unit of analysis. So the two most recent reviews that have been carried out are the one that was done as part of the Public Health in the Arab World effort, and 2 reviews were carried out by Ala Alwan and by Habiba bin Ramadan. Ala Alwan, our current regional director at EMRO, and Habiba bin Ramadan, a professor of cardiovascular disease in Tunisia. The second review was actually carried out by Hanan Abdelrahim from Palestine and currently at Qatar University as part of the Arab World series on health in the Arab world that was led by Huda Zre and Rita Jaqaman from Palestine. So I encourage you to review this paper. This is the most recent thing we have on the Arab world using global burden of disease data from 2010 and really adding an important analysis and recommendations for a way forward. Their paper showed that in which Abla actually participated as a second author, showed that across the income levels, from low to middle to high income countries, NCDs are really important public health priorities. 3 out of the 10 main killers in 2010 were NCDs in low income countries, and 7 out of 10 in each of the middle and high income countries were NCDs. And in this case, the main NCDs being cardiovascular diseases, cancer, diabetes, and chronic respiratory conditions. But the story doesn't stop here. It's not just NCDs are the main, our main health burden in low-income countries and the main health burden in middle and high-income countries. They also kill prematurely. This is data from the WHO Global Status Report for 2014, showing that although as a region, I'm not sure if there's a, I'll just use my pointer here. Although as a region, do you see the pointer? No. Although as a region, okay, although as a region, well, the NCD deaths are not as huge as in some other regions, probably mostly related to population size, but it's actually, we're not doing so well with regards to standardized death rates. And we're certainly not doing so well with regards to premature mortality from NCD. Now, the story on premature mortality will come up recurrently during the day, because this is a key target for our thinking and discussion and public interventions on NCDs. It is premature mortality that is the target. And premature mortality has been a key focus from the year 2000, where now the global agenda for NCDs was first introduced, all the way to 2030. And this 30-year stretch has been about really developing the evidence base and the tools, both in terms of policy interventions as well as technical interventions to tackle these NCDs. And I use a WHO slide because really WHO has led a lot of the global work on NCDs, including at many regional levels. Now, these are the targets, in case some of you have not seen them. These were endorsed by the World Health Assembly, include 2 health system targets, availing medicines and technologies and providing treatments for high-risk individuals, and the rest are risk factor targets leading to the ultimate goal, which is reduction in premature mortality from NCDs by the year 2025. 25% reduction by 2025, thus the 20 by 25 agenda, so-called agenda. So we looked at what can contribute really the most to achieving this target by the year 2025. And this is a paper from the Lancet that shows in our region, as compared with the world, the rate among men is the raised blood pressure, among women is the same. Among men, tobacco use comes up as really the second most important. And just acting on the risk factors alone through essentially a public health population-based approach, you get very close to to achieving the targets, let alone addressing some other agenda items. So this is the regional agenda endorsed by our ministers of health. It's important that we refer to this because we can hold them accountable to this agenda. They've endorsed it, they signed on to it, and includes interventions in the areas of governance, risk factors, health surveillance, and healthcare. And there are 10 indicators to monitoring the progress on this agenda. How well we're doing on this? We now actually have a recent publication from 2015 detailing how each country is doing with regards to implementing that priority agenda that's endorsed at both the regional and the global level. And we will refer to this, so this is just an example of Lebanon, but we could have taken any country. Coming back to the subject of this conference, research on NCDs has been the subject of a global consultation that came up with recommendations, and even an actual regional consultation came up with a set of recommendations, all cool, good and nice. But the agenda on NCDs has evolved so much in the past 6 years that even a revision of that mainstream agenda needs to be reviewed. Now, but this is not enough because there's a lot of advocacy outside of this agenda to see change to the priorities given to various NCDs or so. The mental health crowd really want to see a more focus on mental health as part of the mainstream NCD agenda. The Lancet NCD Poverty Commission wants to see more focus on NCDs of poverty, looking at the poorest of the world, at the bottom 1 billion, that have an actually disease profile that's different than our mainstream NCD agenda. And in our region, very importantly, we now have to deal with this subject of NCDs and emergencies, what to do with this, and whether there's a whole research agenda and policy agenda related to that we hope to tackle in this day. Let me close here and start welcoming our colleagues in this session. It's easy to welcome colleagues who are so prominent in global health. Rob Terry, from the time I worked at WHO, really has a reputation of gold on both the personal as well as the technical level. He's led a lot of important efforts, including the 2000. He was one of the lead authors of the 2013 WHO World Health Report, research for universal health coverage, which has had an important impact. He's worked in many countries, including for Oxfam and DFID. He has actually recently led the WHO Special Program for Research and Training in Tropical Diseases, TDR, and we have the privilege of actually working with him as part of this capacity. So, Rob, a very warm welcome to Beirut, and we look forward to hearing.
Thank you very much, and thank you very much for this invitation. Having previously lived in Ramallah and worked in Gaza, I have to apologize. I've never been to Beirut before, so it's fantastic to be here for the first time. And you have a beautiful campus. I mean, it's a really nice place to work. The environment seems very good. So what I was asked to do was just to give a very brief, and I will try to be brief, overview of sort of research priority setting at a sort of fairly high level and at a sort of strategic level. And a lot of this is based on the work that I've done at WHO and with other organizations. And in a sense, this really just sets a little bit of a frame for thinking about how to organize and perhaps communicate priorities. What it perhaps doesn't do, and as has already been highlighted, it asks the questions, and it'll be for you and others to provide the answers. So I don't lead TDR, I work for TDR, so my director would be very upset if I didn't at least have a few slides on TDR, so there will be a few. So it's a special program of WHO. It was established in 1975, so we've been going more than 40 years, but our focus is on what we now talk about as the diseases of poverty, and I think that's, again, a very interesting concept to bear in mind, but we're talking about the infectious diseases of poverty. As I say, we've been working for more than 40 years in this area. We started very much looking at products and product development and very much focused on interventions, and I'll come back to that a little bit. Where we are today is very much on supporting research for implementation. So in a sense, I think that's actually quite important, and I would suggest for the NCDs that's even more important. It's about how to engage with populations and communities, and a lot of the work that can be done well in NCDs is about prevention, and that's about engaging in communities. Currently, we're working in more than sort of 50 countries or so. We're supporting 100 projects, and as I said, we have a focus on the infectious diseases, those that are borne by vectors, and also looking at implementation. And underlying all that, because the focus is majority on low and middle income countries, it's around building that research capacity, which is so necessary if you're going to do anything in the local context. And we have regional training centers. So in this particular region, we have a research training center based in Tunis. But perhaps more significantly for this audience, we have the beginnings of what I think is going to be a very successful postgraduate training scheme based here in AUB, supporting as I said, implementation research, or research that supports implementation. So that's the headlines done on TDR. Now I'm going to talk a little bit about research priority setting and how that's been thought of at WHO. The main thing to bear in mind, WHO has to deal with a huge scope of different public health issues from the NCDs through the infectious diseases, through road traffic and safety, through a whole range of different things. So when I was asked to come up with a research strategy for the whole organization, it was quite a challenge. But inevitably, what we ended up with was something that can really be applied to any situation. And I would still stand by this. This was published back in 2010. I've yet to find a public health issue where this doesn't work. And in a sense, organizing any research strategy really involves being focused around four main pillars. And those are, what is your capacity? How are you going to strengthen the health research system and the health research system, the health system, in order to deliver your strategy? So very much thinking about capacity. Priorities, well, that's in a sense one of the main focuses of today, but also being sure that whatever is being done is actually in line with what the public health needs are. And we had a teleconference last week, and I think one of the sort of key concerns here, and I'm sure we'll hear about that later today, is perhaps a mismatch between the research that's being undertaken and the priority needs as they're understood. And I think it is always a challenge, but that's a real challenge to ensure that what is being done, and particularly in public health research, has an impact. Standards never sounds very exciting, but in actual fact is really quite important, and it's about ensuring that there is really good research practice. And it can be as straightforward as ensuring that whatever is published is available to others, and so some of the standards would be around open access publishing, for example. It's about good research practice and ensuring that quality is undertaken throughout the whole of the effort. And the last thing, and again, Richard will talk about this later, is translation. There is very little to be gained in research that ends up in a drawer and is not utilized and used. And in a sense, that comes right back to the prioritization process. Unless the research itself has been identified with a view to being used, I'm talking about public health here, then the value of that is very little. And the one bit that people forget about, and I could almost say WHO the same, is the last bit is the organization itself. Is it set up? Is it managed? Is it organized in a way to deliver those four pillars? So that's just at a very high frame. I would suggest any research strategy should try to think about how it's supporting capacity, priorities, what are the standards that's needed, and how the research outputs are going to be translated. The number of principles on the side, again, this is just, they shouldn't be forgotten about always ensuring quality, always ensuring impact. And something which I think may need to be thought about here, which is who is setting the research priorities. If it's only through a discussion with researchers and other researchers, then you'll have a very specific set of priorities, and dare I say it, they may well just reflect the interests of the researchers themselves. One of the things that I did when doing the Research for Health strategy was look at the various methods and approaches, and there are many, on how research priorities are set. Now, this is quite a busy slide, and I will provide the reference in the set that I leave behind. But essentially, there are sort of 9 areas, a sort of checklist, if you like, of good practice in setting research priorities. And I've yet to find this not work in any subject area, whether it's, as I said, infectious diseases or the NCDs or others. And I won't go through the slide in any great detail, but I would highlight particularly the first one, which is understanding the context, and that really is understanding what is the influencing factors on the public health situation that we're talking about. And also, I would talk about the third one there, which is inclusiveness. And I would strongly suggest that in the NCD area, even more so than many other, because so much of it is reliant on behavior, that including the populations and community-based work is absolutely essential to identifying the right types of research priorities, and those research priorities having an impact subsequently. Is it worth doing? There's been very little actually done on the value of setting research priorities and national research agenda. This is an example that we highlighted in the World Health Report in 2013 from Brazil, where a huge amount of effort was undertaken to create a national health research strategy, but subsequently was shown by the budgeting system that the priorities that were raised were matched by the subsequent budget that was actually delivered. That's Brazil. I think it's a fairly unique case in health systems, but it is something to bear in mind. Once you have a strategy, can you actually then evaluate its impact? So I'm not going to go into great detail about this, but again, if you haven't had an opportunity, there are a number of different strategies and tools and background material that's in this World Health Report. Again, I think one of the things where we often struggle is the value of how we communicate the value of research and how that can actually achieve national objectives. There's a number of examples and case studies here. This is a very much a sort of practical guide to that. So something else, again, another tool, and I would also argue I've yet to find a public health situation where this cannot be applied. When you're setting your priorities, is to understand in very broad terms the sort of 5 key areas which influence any kind of public health situation. And that is, do we understand the problem sufficiently? Either its size, the burden of disease, do we have the right data? The next sector for research is, what are the causes? Do we fully understand what is causing it? In infectious diseases, it's often a particular parasite or a vector, but those are very much mediated by the environment that you're in, the nutritional status of the person, and all of these other things. And I would say within NCDs, the influence of many other factors, behavior, environment, underlying genetic behavior, are all things that can withstand research. Solution is the area that most people jump to, and is the one that most sort of people would think of as when you're talking about research, is what are the technical solutions, what are the interventions we need? And that is very much the case. But it can also be, particularly in the NCDs, other types of interventions, not always about the drug. It could well be about a public health education package. And then the last two, the two which I would say are the orphans of sort of research strategy. One is implementation. At the early stages, are we thinking about how this research will actually have an impact? Will it be translated into policy? How will that policy be used? Can we implement that policy? And the last one is really evaluation. Is the intervention and the plan that we thought we were going to put in place, is it having the effect that we wanted it to have. And in actual fact, if you start by thinking about the evaluation before you've even thought about the research priorities, it's a very good place to start, because unless you can sort of measure the impact, it's very, very hard to create research programs which are going to have the impact that you want. And I'm talking about, this is public health research here, research that's applied and has an impact, not just for the creation of new knowledge. Under solution, obviously, you can break it down a lot further. And again, because a lot of the work I've done is within the infectious diseases, this tends to be around those types of solutions. So you'll see, drugs and vaccines and diagnostics. But again, they also apply for many of those. Do we have gaps in those areas? Now, a lot of research strategies tend to focus in these technical solutions, which are obviously needed, but maybe overlook the implementation and those other things as well. This very simple scheme is actually quite useful, again, if you're trying to compare across different diseases and different disease approaches. And I have an example here, again, it's from the infectious diseases, because that's where I work, but you could certainly apply that. Now, all I'm trying to show with this graph is that under these different diseases, the shape of the research programs are very, very different. Now, all that does is allow you to have a sensible conversation. Have we got the right strategy in place for each of the diseases that we're looking at? So just bringing this back to the focus of this particular meeting. As we've heard, there is a global action plan in place that's going to run till 2020. But in fact, when you read that, they really only used under the research section the outputs from that report from 2011, which I think in broad terms is still fairly useful, but in the specifics isn't. And then, of course, if you go back to my earlier slides, the context right now, this was before many of the conflicts that have, are in this region. So a lot of the priorities which are identified here perhaps are not covered. But again, you'll start to see some of the same areas that in the high-level WHO strategy are repeated here. So putting the NCDs into the global agenda, research to understand what are the determinants, translating those into the health systems. And I think something which is quite necessary, particularly within the NCDs, is these access issues about there are many treatments available, many say, for example, cancer treatments, but extremely expensive, difficult to provide the access. So just the last slide is just a very brief summary of those research questions. This is just to sort of get us on. You can see very much you could probably do this yourself, cardiovascular disease, cancer, respiratory disease, and diabetes. Interestingly, nothing there about mental health, of course. The risk factors, which perhaps we know. And then I think another good way of thinking about research priorities in this sector is these kind of cross-cutting issues about how is primary health care, how is the health system set up to cope with treatment, and then promoting research practice. There are a number of research priority areas that are described in this report. I would say they could definitely withstand some revision. And for this locality, of course, context is everything. And so I would say the high-level framework is probably useful, but once you get into the specifics, it's a different story.
Thank you very much, Robert. Thank you, Dr. Terry. So we move, we'll have a Q&A at the end of the presentations. We'll move to Professor Richard Sullivan. Richard is, like Robert, also a new friend of AUB and of the faculty, and we're really very excited of collaborating with him. I'm not sure where to start. Let me start by something that really requires us to knock on wood. He has run 5 different Lancet commissions in his young life. We're barely struggling with one. He's a professor of cancer and global health at King's College London. and is director of the Institute of Cancer Policy and co-director of King's College Conflict and Health Research Group. So his work really spans multiple areas. He's a past director of Cancer Research UK and of the Council for Emerging National Security Affairs. Why don't I stop here, Richard? I'll just give you more space so you can spend on your presentation. Thank you.
Thank you so much. Well, good morning, Sabah here. Lovely to be here again, my second time, and it feels like home already. So that's absolutely fantastic. And thank you for saying young. I have a personal interest in the NCD agenda as time marches on. So this is a huge topic to cover in about 10 or 15 minutes, and these are personal views that I've tried to distill down from an awful lot of work by a lot of other great minds and individuals. I want to start by really talking about the tectonics of NCD research and policy. There is just a reality. Some things in the research and policy agenda move at glacial speeds. Other things move incredibly quickly. So the differential dynamics are really quite complex when you're dealing with this as a global movement and trying to understand the context of regional policy in global areas. But if you talk about things like what's at the cutting edge, where's the small Lebanese flag at the top of Everest? Well, here it is. It's precision medicine. And the reality is now in NCD research globally, precision medicine is one of the dominant paradigms that's driving everything. And I know we'll talk a lot about public health over the day, but this has to be borne in mind because in a sense this is where a lot of the speed and the light and the heat and the money is actually focused. We're also dealing, I think, with a research agenda across most NCD areas now that is becoming dominated by a technocentric paradigm. It's focused on all these very high-end technologies which are being used and driven within healthcare, which is still essentially an old art of human being versus human being. May I say, curators get very upset when you go into their museums and you mock up these sorts of pictures. So I really don't advise doing this, but it was worthwhile to get this picture. But the technocentric paradigm really is dominating. The other problem I think we're facing when we're thinking about the research to evidence and actually translating research into policies that are going to improve patient outcomes is for whose benefit. The precision medicine paradigm is about the individual. On the other hand, the public health paradigm is about society. And there's an enormous tension, I think, at the moment in the research to evidence around the needs of the individual potentially outweighing the needs of society and vice versa. And this is something I don't think anyone's really grappling with very well. I've got three very brief areas I want to talk about in terms of the evidence to policy. Something about the context of this, the economics, because the economic policy frames a lot, and then I want to end up by just talking about power. That's something I'm quite interested in at the moment. I enjoy a good action movie. I do enjoy Robert De Niro here in Ronin. And there's a very famous line in this film which says, "The map is not the ground." We rely a great deal in evidence to policy on epidemiology, demography, economics. But those figures and numbers are very different from the political reality and the social and cultural reality of individual countries. And the reality is the information we need for allocation decisions often fall around cost and benefit. Actually, the disease burden, which we get very obsessed about and focused about, and I understand why, also as a public health doctor, often does not figure in policy making. It is all about what are the costs and what are the returns I'm going to get into my country or my individual area. Also delivering the NCD agenda that reflects the real need, I think, is really very, very challenging. Again, we talk about prioritization based on need. What people actually do in the NCD research agenda is often based on what they want to do, and then we justify this afterwards. And I think the deficits are both on the evidence and the policy side. So the deficits in the research that we do in order to inform policies, and even if we have the research evidence, if we have poor political and policy making, we can have the best evidence in the world. It does not get translated. And as Robert mentioned as well, there's also that gap in between moving the evidence into the policy area as well. Also, the evidence to policy, the volume in many areas is outstripping our policymakers' ability to handle this. Just in cancer alone, look at this. We're nearly at now, actually this is an old figure from last year, we're now producing nearly 65,000 publications a year purely in cancer. Just in high-income countries alone, there are nearly 45,000 senior investigators. the sheer amount of evidence and intelligence coming in, it's impossible for people to handle at the moment, and this is a real challenge. And I will also say that high income data and for high income countries and research for wealth, not health. When you look at this, it's very easy to find, it's very difficult to find the right data, and it's very easy to find the wrong data. In other words, you can cherry pick like crazy a lot of the evidence to fit whatever policy you want. And narrowing down the choices for rational policy making, I think, is becoming a real challenge because of the amount of work that's coming up, often that contradicts each other. Today, Brussels sprouts give you cancer, tomorrow they protect you from cancer. It's a real difficulty here, and I'm just paraphrasing that. Also, progressive universalism and NCD policy making, this is what we have all signed up to, this idea of delivering UHCs through a progressive universalism approach. And how on earth do we get private interest in the service of the public? We see the challenge that's come out of the high-income countries, where at the end of the day, it becomes about funding NCD research for the wealth of the country rather than for the health of the populations. And I think that's probably NCDs as well. Let me just taking the pulse of my wallet. My daughter's got a hand on it. It usually has to be defibrillated. Into a wallet, adrenaline, you know, that's the effect. The benefits of R&D policy. Well, the first thing, we're very poor often about selling this to policymakers. If we do research, what benefits is this really going to deliver? Now, the reality is better patient outcomes. That has a monetary value. We're often very poor about doing this. We talk about life saves, mortality. What we don't tell our ministers of finance is how much money that's actually going to save them down the line. And of course, by delivering more affordable care, if we link it to suitable downstream mechanisms, we're also creating better value for the budgets. But again, this is a Trojan horse, and again, using the evidence wisely to change policy often has to be done in this manner. So building the case for public investment is absolutely essential, both in research and for research on policy. But the benefits of research and development are a matter of a perspective. If you're here at AUB, you're here at the top of the wave, you know, you're surfing the big kahuna in Hawaii. This is fantastically exciting work. If you're the policy maker, you're looking down the line here, and what you're seeing is going to be a tsunami with new technologies, with more demands for research funding, and you're thinking, what on earth am I getting out of this, and how am I going to justify it to the budget? So this is a real problem. The other issue here is about the economic policy in NCDs, very much driven by externalities. Robert mentioned very eloquently about the individual UNCs, SDGs, and the deliverables on the road to 2030. But the reality will be that if you look at what's happening from country to country, your governments are going to be driven by different drivers. And they may be global drivers or they may be internal. And actually working out what those drivers are for policy making is in my view, completely essential. So the final bit really is about power, the power to change things, the power to drive research into evidence and actually then train the evidence into policy for the betterment of patient outcomes. My view in this is you do need to stratify and simplify NCD research and translate it into policy. I completely get talking about NCDs as a group for prevention, for public health, for social determinants. But once you move into care and palliation, you have to break these apart. Mental health is not the same as cancer. Diabetes control, the systems for cardiovascular care. And the reality is a lot of these systems of care and prevention are black boxes to policymakers. It is acknowledged that politicians are not that smart, by and large. And you can understand why. If you just something takes something like cancer, or we mentioned cancer as well, it is a black box to most policymakers because of the sheer depth and complexity of all the treatment pathways and regimens that we have to deal with now. Dissecting that out into simple evidence and changing policy is the big challenge. But that's part of the problem here is the black box effects in policy making. The other issue, I think, in delivering evidence to policy and the power equation here is we make an assumption out there that there is somehow some big public movement that will get on board with all the things that we think are going to be good for them. And I talk about a them and us here simply just to illustrate the issue here. The reality is, from all the evidence, that political framing of evidence to policy is not open, and it's often not sensitive to social constructs. What I mean by that is usually there are inner cabals which control all this. They may be special interest groups, bureaucracies. I use Congress there, but I mean Congress of politicians. And dissecting out who those special interest and cabal players are is essential. Just actually asking the public to help you often doesn't change anything. There's no power there. But you need more than that. There are a lot of ideas around, and there's no lack of ideas. And the real question for me is, which of these ideas will catch hold? And when you plant a seed, you do need rain, you need soil, and you need luck for it to germinate. And there's also a need to understand the decision making and how you take the research evidence and translate it to policy. And there's all sorts of different approaches in public policy making. I'm not going to bore you to death with them. Rational models, incremental models, and of course the much beloved and often used irrational model. Each of these has its benefits and deficits. A lot of this requires research into political economy and policy making. So social science, political economists are as valuable in the research effort in NCDs as clinicians are, physiologists, etc. And how does one influence the NCD apology agenda? Because I think that there's a danger that you have big meetings like this, you do lots of exciting papers in Lancet and other places like that, but the reality is you end up being the Greek chorus. You comment on the main action, but you don't actually influence that state at all. I quite like John Kingdom. He's one of the big political policy makers, one of the doyens of this, and he talked about three things: problems, policies, and politics. Defining your problems using evidence. This is the research best. Looking at the variety of policy intersections to deliver the solutions to the problems, and then marrying and aligning the political will to actually change things. And of course, as Michael Marmot said, it's all about making sure you have fair society and healthy lives. And the issue of actually having a principle up front that this is about equity and affordability is essential. And I don't think there's a simple equation to any of this. I just have four things I've just dissected out right at the end, just for thought here, really. The first is this one. Improving outcomes means improving research expenditure. But I think investment is only part of the solution here. It's also about structure and organisation of care. Also, making tomorrow's NCD burden feel like today's political issue, I think is a major challenge. If Ebola, were to hit the shores of any country, people would suddenly rush around and put money into research and change policies of infectious disease because it's acute and urgent. NCDs feel a long way down the line, and making politicians feel like it's today's problem is a real issue. Evidence has to be actively integrated into policy making, so there's no good just doing papers and expecting those papers to be picked up. Somehow they have to be pushed into the political policy making, but it's still essentially political. And that means being on inside that massive iron triangle. And finally, and this is the bugbear I always have all the time, is we know every bit of evidence points to the fact that inequalities are worsened by allowing market forces to determine how your research evidence affects policy. So groups like these, steering groups which can take a rational perspective of public good and public policy are absolutely essential. Because otherwise the technocentric paradigm tends to push things the wrong way. Thank you very much.
This is unworked professional sciences. Man's from which angle I would want to start, because he has really made contributions at multiple levels, from the institutional all the way to the technical. From the technical level, his main area of focus is occupational and environmental health research. He's a member of the editorial board of the International Journal on that same topic, and is a fellow of the Collegium Ramazzini. He was inducted to the Johns Hopkins University Society of Scholars. He's the editor also of the book, co-editor of the book Public Health in the Arab World. But perhaps equally importantly is evaluate its institutional contributions and leadership over the past almost decade of this faculty that reflects his belief in interdisciplinary and community-based research, where he has been able to really bridge specialization in medicine, public health, and environmental and occupational health. Why don't I stop here, Dean, and give you the mic.
Thank you, Simon, and good morning, Sabah al-Khair. And so I'm going to take my presentation actually is, I think, purposely sandwiched between experts and experts. So I wouldn't claim that I'm an expert in SED, and I wouldn't claim also that I'm an expert on research. What I'm going to share with you is sort of taking you a little bit out of what could come across as the core of today's agenda, and perhaps taken a bird's eye view of what's happening in the region. So today's meeting will focus a lot on the mapping, the scoping, what's out there, quantity, quality, relevance, and impact. And I think the two speakers have actually also taken introduced several dimensions to add to all of this. But again, if we're talking about changing research and shaping research in the region, I think there's a lot of understanding why is the quality high or low, why is the quality good or modest, and is it relevant, and why is there impact or there's no impact. And hence, it's almost like we're looking at the social and political determinants of research. If you look at the number of scientific papers in the region, you would see that there's actually a sharp increase in different regions, and so there is increase in the absolute number of papers that are being produced. And look at across the different fields, it's almost doubling or tripling in some cases, and this is medicine and clinical, this is environmental sciences, social sciences, and you see that there's quite a sharp increase actually in the number of articles that are being published in the region. However, although this goes back to the 2000, however, it's still true, and more evidence is coming showing that we're still, as a region, we still actually rank at the bottom of the world in the number of publications. And so we're less than 1% of articles published in impact factor journals. Not much is invested in research, and so on and so forth. And going back to this figure here, again, you see that it's true that there's increase in research in all regions, but you see also the sub-regions of the Arab world, but you see quite a gap. In some cases, this gap is actually closing, but there is a difference between different sub-regions in the which again takes you to the point of how come research in some countries and in some regions, sub-regions of the Arab world is doing better or worse than other places. Sari Hanafi from AUB has looked at the research productivity in the region, and he was able actually to sort of group the Arab countries into different categories. And so these are the countries here, and you see that they're Saudi Arabia, Algeria, Morocco, and Egypt, and he classifies them as countries with large research system but slow growth. Lebanon, Jordan, and Tunisia are classified as small but dynamic and integrated research systems. So they're producing, but they're small. You have a bunch of countries here that do not qualify into these, and then you have the countries in the GCC here. They're small countries, but they're producing because of the high investment
and resources that are actually invested there. And I want to take AUB as an example. Not only because we are at AUB, but if you look at the numbers, in Lebanon, the Lebanese National Council for Scientific Research puts out more than $1.2 million a year to support research in the country. AUB alone actually practically receives perhaps 60% of that $1.2 million to support research within the university. The number of publications in this university practically is more than all publications from all other universities in the country. And that actually poses a question: how come a university can do that? And it goes again back to the issue of the things that can be done at the institutional level that perhaps universities across the region can also adopt. And these are not really unknown to you. Actually, adopting research as a primary mission of the institution is a major driver. Setting administrative bodies to facilitate and support research. And this is, we cannot belittle this, although many of us complain about some of these bodies, but these are the bodies that actually sort of not only legitimize the research, but it actually sort of improve its quality and indirectly also its impact. And it shouldn't come as a surprise to you that in most of the universities in the Arab world, these bodies do not exist. Providing internal funding and facilitating access to external funding and some kind of monitoring and evaluation or a promotion system on merit and others. And AUB now is in the process of adopting tenure in the university. So the other level is actually the whole idea of encouraging and facilitating cross-departmental and interdisciplinary research, adopting university-wide priorities, and tenure, as I mentioned, to allow for risk-taking and innovative ideas. So these are things that can be done at the level of the institution. And if you scan the region, you'll find that in the vast majority of universities in our region, these things are not there. And the question sort is, why is it so? And so in what environment, what is the environment that we all work with? What's the environment that actually defines our research or impacts it? This is, we're not, as mentioned before, this is not a homogeneous region. This is quite heterogeneous, and it's the inequalities in our region are quite striking. And perhaps are the most striking of all our regions, where actually wealth actually sort of lives side by side by extreme poverty and malnutrition. And again, this is a slide that was shown before. And if you look at the different countries in the region by income, you can categorize them there, and you find that the burden of disease changes there. But again, there is a dimension here that we need to look at. So we tend to look at the burden of disease, but again, low-income countries means that there are no funds or minimal or low investment in supporting research, most probably in these countries. It means that your universities are not well endowed. It means that most of your professors and researchers might hang around for a few years, and then they have to leave somewhere else for better living. So again, as we look at the burden of disease, there is this sort of, dimension of looking at the resources and the system that could help actually the country get out of these issues that we're dealing with. The other environment, it's again, this was published in 2014, and we're the only region that spends more on military on military than on health. Look at this amazing diagram here. And the data here was actually taken from US sources. So this is what US sells in arms to our region and other regions too. And so the blue here is what is spent on health, and the colored here, the red, is what we spent on military. And this bar here is the ratio of health to military. And you see that in all regions, there's more expenditure on health than on military. In this region, we spend more on military than on health. This is 2011, by the way. So this is peacetime. This is peacetime. Just to give you a sort of a quantification, in 2011, this region bought more than $60 billion in arms. $60 billion in arms. I think we're spending much more nowadays. It's a region in turmoil, which means, again, when we think about research, we're only not thinking about the ability to produce and the ability to do research, the fact that universities are now depleted of its resources and of its people, their ability to conduct and collect data. But again, we could look at these as opportunities to think about research differently and to do research that is relevant there. And this is again to emphasize the point that our region actually hosts the highest proportion of refugees in the world, both in absolute and per capita, and Lebanon actually is leading in that. Our universities, after all, when you look at all of this, and I used the example of AUB and spoke about the other universities that may be doing as well or perhaps better or less, but the universities do not survive and live in a vacuum. We as researchers, as professors, we're actually not only parts of universities, we're parts of society and citizens of these societies and impacted with what's happening. I don't think it should come as a surprise, again, to us that in most of these universities, there's a heavy-handed political intervention in these universities. This whole sort of concept of free thinking, inquiry, and doing research that is relevant is sometimes halted by the fact that the structure of universities and the policies of universities and the politics of universities are determined from outside by external political forces. We talk about Lebanese universities so that people don't think that this is just an example out of context. We talk about our Lebanese university, and you'll find that a lot of the appointments of the leaders within the universities are actually political appointments. Would this hold research? Maybe not. But the fact that the leaders of the university, rather than carrying a vision for that university and research and education, are also reporting somewhere else. It's striking how disconnected actually scientists and institutions are in our region, in addition to again, a lot of brain drainage that characterizes it. If we come to the issue of knowledge to policy, again, there are a lot that have been mentioned here, whether it is inadequate resources. But I'd like to take this again because it's connected. So these are many, many articles that have looked at this whole issue of barriers there. And the whole issue of poor value given to research, again, reminds us of the fact that these are social values, these are political values that are determined by political structure. Are there signs of improvement in the region in spite of all what I mentioned about? All the challenges, the resources, the conflicts, the refugees, the displacement. Yeah, there are a lot of now more actually regional foundations that are investing in research, and this is actually a very good sign that many are benefiting from. There is more international funding that is being directed to the region. There is more interest in different countries on setting their national research agendas. This is looking at some of these national health research systems. There's, of course, a lot of variability in the countries, but again, national health research policy, plan, strategy, 2 countries here, national health priorities, 6 countries have set some of these priorities that could guide research and actually also direct funding. Overcoming some of these barriers here, again, building the capacity of researchers, we've heard that, but again, building the capacity of universities and research institutes. And I think this is something that's quite missing when we talk about funding agencies. The focus is mainly on building the capacity of researchers. And I think the only few funding agencies think about actually building capacities of universities and different programs within these universities, because it's the universities that are going to provide the right environment for researchers to produce. Stakeholders, collaborations between research institutions in the regions, many attempts moving in that direction, not much, but more should happen there. Aligning research with community and prioritizing research at a national level. We should see it and work for it as a tool to advance knowledge and, of course, to inform policy and practice. But then it goes back to the whole point of, okay, now that we've diagnosed all these challenges that face us, who can take action? We were extremely hopeful that when people took to the street, and actually we wrote about it, and we spoke about it, and we thought, and we were convinced, and personal bias, still convinced, that the fact that people took to the street and said things should be done differently is a big message, is a mobilizer, is a driver for change. So people can influence and can direct priorities and decide on a cleaner, more transparent political system, and that should be good news for research and for research universities. Yes, I do say that to take action, we talk a lot about technical steps. We talk a lot about how to do step 1, step 2, and step 3, and these things should not be forgotten. But yes, to support research in the region is actually a political agenda. And there is a need to bring in research as a value, to bring research as a priority, and to allow space for free thinking and research that is relevant. And there's a role for different organizations at all levels in doing this. Public health infrastructures need to be protected. And there's more move towards privatization in the region of the health sector. And there is more a stronger move towards the sort of the technical side of providing care. We need to advocate for an engaged role of universities. And we need to strengthen the discipline of public health. So far, public health is being taught within departments, which is good and needs to be supported. But there is a need for schools of public health that carry a different framework looking at health, a population health framework, a more of an equity and seeing health as a social construct. And I cannot sort of overemphasize the need for regional networks of researchers and of academic public health institutes, something that our faculty has been quite engaged in. I finish by just saying that one of our attempts, and it's a model, and different universities and schools could adopt their own models. But one of the model that we've adopted is actually transforming research, policy, and practice from the saying that it's not the burden and the responsibility of the individual faculty member and researchers to do that. It's part of what they do. But as an institution, as a school, we're committed to these three functions. And that's why we have three centers: Center for Research, Center on Knowledge to Policy, and Center on Public Health Practice, that work together to advance actually all of this and provide the platform for these things to happen beyond the capacity and the availability of the individual faculty member. And thank you.
Thank you very much. Okay, if we can have the light. I do have several questions for my colleagues on the panel, but I think we'll pass the mic over to you. If I can see a show of hands for those of you interested in posing a question or raising an issue. Okay, we'll start with Dr. Rashidian, Arash Rashidian from WHO EMRO. He's the director of IER, Information, Evidence, and Research. We're very pleased to have you with us here. No, can we pass a mic? Is there a mic?
Just, first I want to represent it's a pleasure to be here, and thanks for the invitation. I want to one of the several topics we discussed further. On the challenges that so it's direct to your presentation that you raised, I had a further one, which is my personal observation, but there is a plenty of evidence for it. It's a sort of, I would call it disciplinary failure in terms of research methodology. And by that, I'm looking at what happened to nutrition evidence in the last 4 or 5 years. It started with the sort of changing the recommendation for whether egg is a healthy thing to eat or not. And it was actually not because we hadn't researched the effect of, the cholesterol from egg in eating. We had researched it, but wrongly. And then we realized the design was wrong, when a cohort study came out. And then that started to changing all the advice that is coming, the things that are coming in the last 2 years in terms of other advice on. So in a way, are we applying the right research methodology in the certain discipline? So if it becomes the sort of the paradigm in my discipline, then we repeat each other's work. I had also a personal example before joining WHO, when I was in Iran. In my country, one of the most expensive public health interventions that we do is that we try to reduce the amount of sodium bicarbonate used in producing bread. Bread is very popular in Iran, as it is in this region. It's a very expensive when we did a systematic review, and what is the evidence behind it as part of a sort of question that almost none, zero public health, human level study that shows there is a negative effect if you use it in that level that you produce the bread itself. There is, what would be the advice on that? How can we challenge that? And my worry would be on another issue that is very common also in certain disciplines related to NCD, is the abundance of ecological studies that very plainly ignore ecological fallacy. We all know that that's a problem. But the discipline is producing and overproducing. And this is also happening in some of the burden of disease studies, some of the sort of arguments that we make about the consumption of certain things related to drug, to alcohol, the cigarette, the things that are more difficult to measure. So what would be the approach on that? If you are thinking at it from, if the discipline itself, cannot find the problems that are existing there.
Why don't we take a couple of more people, and then we will move on. Professor Rand Ahmadi, if you would be kind to introduce yourself. We had earlier the mic, can we we use that as well? Okay.
Randa Hamade, actually, Arabian Gulf University. I'm the Vice Dean for Graduate Studies and Research and Professor of Epidemiology. I'm very happy to be here with my friends and colleagues. Thank you all. From Bahrain. I have a question which I would like to raise based on one slide Professor Noy had put. And it always worries me, maybe you have an answer as a panel, the lack of public accessibility for data and the ownership that we think that it is ours unless you put me as an author, I will not give you the data. That's part of those in service. I would like to see what is happening in the West with respect to this aspect. Is it that we have to keep engaging non-academicians in order to have research, our research done? Is it that we have to convince those who have the data in ministries of the importance of research, or what is missing? Because this is a big issue in the Arab world. And the other issue is now, because of the region, the problems in the region, population studies, going to households is becoming also, I think there is a lot of decline in conducting surveys at the household level. So if there are solutions for these, I'd like to hear some. Thank you.
Thank you very much. We'll take a third intervention. Yes.
Good morning, Ghada Al-Haj Farhan, Faculty of Medicine, Endocrinology. One of the issues we've debated and struggled with and are still struggling with is the issue of networking and collaboration, not only within an institution, but as importantly, across institutions and countries. This was a major obstacle for education advancement. This was discussed by President Khouri in a panel last year, and I think it's a major obstacle for us. We've heard about differences between results of studies from various countries. I think trying to network and establish cohorts or design issues on major public health issues that cross over across countries will help capitalize on little resources we have in each country to advance research. This has been really a major obstacle. Funding to do research, funding to do good research, various priorities, design methods, but even allocations of resources for the major questions across country. I mean, Lebanon does something and Jordan does something else, and it's picks and pieces here and there, and you cherry pick, as you said. What is the role of the WHO, or what is the role of organizations that are supposed to bring us together? We have a network meeting once every few years. It's more or less too much to absorb in one meeting. The NIH, with its NCD agenda, had a networking meeting 4 or 5 years ago, and then nothing happens. So what are we effectively doing to establish these networks and to empower them to move forward?
Okay. Thank you very much. Why don't we give the panelists a chance to engage with the audience, understanding that we are coming very close to the end of the session. So Abla, if I may, I'll ask that we eat a few minutes from the break. Perhaps I'll go on my left and move forward. Richard, would you like to engage with some?
3 very quick responses then. First to the question of research methodology, I agree. The issue of bridging qualitative and quantitative skills is absolutely essential. We spend an awful lot of time disciplinary-wise in clinical, social, and we don't bring these together enough. And the role for universities in actually bridging these different specialities is essential, but the divergence is being driven often by the depth of technical expertise that's required now in individual domains. And we're forgetting how to speak other languages because we're never trained in those other languages. And I don't have an easy solution for that. The issue of public accountability and data, there are strict criteria laid down now in many of the major medical journals and also by the research funding organizations. I'm going to be blunt, the evidence indicates they are variably implemented. The reality is investigators which hold on to data can still radically slow down the accessibility of that data by a variety of methods. And I still think that's a huge, huge problem. We get it in clinical trials in cancer, and we're supposed to be incredibly transparent and open about those things. It doesn't happen. And then finally, on the networking collaboration, part of the problem as well is high-income countries are not building capability research funding to allow these sorts of networks to be sustainable. They give you a little bit of money and then the gate shuts on that. That's the NCD Alliance for NIH. And there's no long-term strategy on partnerships between high-income and ODA countries. It's starting to change a little bit. I don't know what Robert thinks about that, but I don't see any radical movement on that at the moment. But as you said, it's absolutely essential to build up the research capability and capacity in countries like Lebanon. It's not about building up back in the UK.
Iman? I think the questions are quite interconnected, and so the lack of public accessibility is an issue that we all face, and I think we're not even at the level of saying whether researchers share data. Actually, in many of the countries in the region, the governments collect data and they keep it for themselves. You have no access to data that has been collected through taxpayers' money and through the government's budget. And you ask for data and it's not given. And there's even sometimes a requirement for publications in one way or the other. The networking is something that our faculty has been investing quite a bit in. We have a reproductive health working group that is regional, more than 20 years old, a tobacco control regional group, a group on agriculture, environment, and health. We have a group in childbirth. And absolutely what you've said, Dr. Fleihan, is absolutely correct. These networks and collaborations open opportunities and provide support. I think you've taken it even to a higher level of thinking about some kind of a joint research across the Arab countries. In some of the countries now that are afflicted by conflict, some of the researchers that are part of these networks come to these meetings, and it's a breather. They actually say that. It's a breather for them to come and talk research and talk to others and share some of what they're doing and participate in what others are doing, because they cannot do much of this within their country. Connecting the two together, I would go back to the whole issue that it's vastly political. And when I say political, I don't mean demonstrations and political parties. I mean that there is a role for universities and for researchers to actually push and advocate for these principles and not take them for granted. Claim our rights. Our right to actually access of these things. Not an easy thing, simply because we're quite dissociated.
So on the first question about research methodology and how it needs to improve or be reviewed, I can only agree. As I said in the framework, I think one of the orphan areas of research on research is impact and is the outcome the one that we predicted. I think there is something that can be done about that, and that is ensuring that certainly for larger projects there is a systematic review as part of the essential background to conducting the study. I think I was rather surprised, and I think everyone should be rather surprised, that less than 1% of all clinical studies are actually repeatable or repeated. So we have to be absolutely certain that when they're done in the first place, they're done as best as they can be, because it's very hard to fund a clinical trial in the first place. To repeat one, to get funding for that is almost impossible. So I can only agree with you, but I do say that eventually things are self-correcting in time, but it does take time. In terms of data, I think there are two parts to your question. One is access to public data, which is moderated by governments, and the other one is access between researchers to data. Is that right? So there is some movement on both of those areas, certainly with regard to data. So I did a lot of work on open access to publications when I was at Wellcome Trust. And now the focus is on data. It's actually a very different scenario, because data is extremely complicated and different in its different contexts with regard to privacy and confidentiality and how it can be shared and those types of things. So I think my view is that it's unlikely to come from the top down as a kind of blanket policy other than a general principle that sharing data is better than not. So taking that on, at TDR, we've been actually sort of experimenting sharing data by doing. And we've had 4 different platforms that we've established, working very closely with the research team. So we've done one with TB clinical trial data. We're doing one right at the moment with schistosomiasis and helminth data. And we've done some with data that was collected during the Ebola crisis. Now, what this is beginning to show is that there are, as a starting point, and I think I could probably spend the rest of the day talking about data and how to share it, but on the starting point, one of the best ways of getting researchers comfortable to share data is to have a managed, or what we call a managed or gated system. So the data isn't made freely available to all and public, but it's actually mediated through, say, a data access committee. And we are beginning to realize that if you can do that and put in place those kind of safety procedures, then the researchers themselves have a reassurance that the data is not going to be misquoted, or even worse, that somebody's going to repeat their analysis and find a different conclusion, which researchers are very scared of. So there is some work on that, and if you like, I can send you the various guidelines and things. In terms of access to public data, one of the things that WHO is doing is it's going to be, I hope within this year, releasing its data access policy to the data that's collected by governments and sent through to the Global Health Observatory looked after by WHO. The approach is that it will be open and it'll be for non-commercial reuse, so using the Creative Commons approaches. I think this will be a first step. Other organizations, so for example the World Bank, all of its data is now public. So all of its household survey data and everything is now public. And so I think we're at the beginning of a particular movement there. And finally on networks, well, I think we can only all agree how the significance and the importance of networks, but funding just for networks is I think, almost non-existent. They has to be integrated within a bigger research proposal is the way that I would always have said it. And any of the reviews that I've ever done with networks, the key thing, or the thing that comes back time and time again to a successful network, is that some person, and usually is a person, that some resource is given to the coordination activities of the networks. They're not really organic things. They actually need to be managed and actively managed. But I would say the best sort of solution to that is to actually build that into any research project at the beginning, because it's almost impossible to separate it out as a funding activity.
Absolutely, but where are the funds to make that happen and engage countries to establish the network and go forward with major research projects? I wasn't implying funding for networking. I was implying for, since the ministers have signed on certain priorities in our countries, why aren't one or two picked and funded by major organizations? I'm not sure what, but what's the role of WHO in that? And why aren't we establishing a competitive application where 2 or 3 countries may come together and address 1 or 2 priorities in research projects, but the network is part of engaging in that research project? And this is what I think is really sorely missing in our region.
So I think, Robert, you'll take this to the Director General, before, especially the new one will be coming soon. Why don't we take a second round? We can take...
Samer, I have
oh, yes.
Okay.
Please.
Just a quick, to add one additional angle to the issue of networking. I think networking with the policymaker is quite important. I don't want to present some of the findings of our scoping review, but we have found that papers in which there were the publications, co-authors and collaborations between the academia on one side and the public sector and the policymakers and NGOs on the other, has not only had a higher impact, and there are several criteria by which we studied impact, but also the publications in countries which had more collaborative efforts with policymakers and NGOs were paralleled the disease burden. So it was responsible research and it was appropriate research.
Thank you. Okay, the second round we can only we're already into the break. We can only take 5 minutes. Okay, thank you, Suha, for putting us on track. 5 minutes, so I don't see any hands up. I think everybody is giving us the message that you're ready for your break. Why don't we break right now? But before we break, let us give an applause to our panelists, and thank you very much for your time.